Hi, Dr. Gonzalez here. Thank you for taking time to watch this video on tethered oral tissue, or like I like to call it, TOTS for short. TOTS are restrictive to our muscles, our tongue, our lip, and when there's a restriction, when you have a tie, you're unable to function correctly. Therefore, symptoms can arise. If there are symptoms and a restriction, there is a tie. And most babies and children, adults with ties should have a release. But it's that timing, that effort with collaborative providers that makes it successful outcome. For infants, I really wish all my infants saw a lactation consultant before they saw me. That would be my absolute ideal situation. It can't always happen, but I wish it could. For my older children, 6 months and over, I wish all of my babies, my young infants to toddlers and children, had a myofunctional therapist on board. From there, it's kind of a, different collection of providers I select from, customizing it to each patient's restriction and the symptoms that they're dealing with. The older we are, the more therapy we tend to need. So catching a TOTS or a tethered oral tissue early is beneficial for our long term. If our tongues aren't being properly used, they sit low in our mouth. They should always be up in the roof of our mouth. Our tongue always should be suctioned basically to the roof of our mouth when we're not doing anything except chewing, speaking, crying for infants. Then, okay, yeah, it's gonna go low. But at night, sleeping, during the day when we're doing nothing but, hanging out, our tongue should be in the roof of our mouth. With each swallow, that tongue's resisting and balancing the muscles that are always driving our face inward. Those muscles are our facial expression muscles, our masticatory or chewing muscles. They're always moving in. And if left unabated, these muscles will push our jaw into such a crowded dentition, cross bites, open mouth breathing postures, tongue thrusts, reverse swallows. I could go on, but all of these dysfunctions can lead to quite an expensive treatment with a lot of therapy later in life. Catching this early is critical. As an infant, it's best to do release early. But again, lactation support is ideal. Sometimes craniosacral therapy is necessary. Sometimes we even need feeding, occupational feeding therapy, physical therapy. And for each patient, I really assess where their dysfunction is and how restrictive they are, and customize the collaboration with the providers that are going to be the most beneficial. Same for the children, our older children, our younger adults, I see up to age 18. For these patients, again, customizing a treatment plan is critical. Most infants, most children 2 and under, I can treat same day. They usually don't have any provider they've seen beforehand other than maybe a myofunctional therapist for those 6 months and over, or a lactation consultant. And that's okay if they don't have anyone, but it's ideal if they do. For those patients, same-day treatment is often a great way to go, and then we can follow up in a week. 1 week follow-up, I really demand or try to for all my patients, because at 1 week I can see how they're healing. If the parents are doing wound management for my infants, 2-year-olds, they're actually preventing these ties from growing back by doing some lifts or stretches, so to speak, and I'll go into that in just a moment. For my kiddos that are cooperative enough to perform a functional frenuloplasty, where they're functioning, moving their tongue, their lips for me, so I have the best exposure to the fascia for the best outcome and the best release. They're often usually cooperative enough for sutures, and sutures are an ideal closure to the wound and most often result in no reattachment at all. Nothing's 100%, but it's very close to 100%. For parents that are doing the wound management, and my younger kiddos, my kiddos that are not cooperative for functional frenuloplasty sutures, those parents, depending on where the child's at, will have different approaches to the stretches. So I mean, say for an infant, no teeth is involved. Usually finger pressure alone is enough to guide you in. It's still tricky. No parent enjoys doing these lifts. They've never done it before. I have to put my fingers in my baby's mouth and do a lift. It's difficult. Nobody enjoys it, but it's so necessary, and it needs to be done, especially for the infants, 3 times a day, every 8 hours. The good news is it's only 5 seconds per lesion. So if we did a tongue tie, that would be, basically a 24-hour wait period. The next day, the parents are going to stretch that tongue back off the floor of the mouth so it's flat with the floor of the mouth, the tongue and the floor flat, about 180 degree. They're going to do that every 8 hours. Smartphone alert will help, and they're going to do that for 5 seconds per hold. Now, if we have a lip tie release in there as well, lip ties we start stretching a little earlier than 24 hours. We start stretching those at the first 8 hours. And then we're going to do that every 8 hours. So on the third time, that 24-hour cycle, we're going to do the lip, stretch first up all the way to the nose as high as it'll go, 5 seconds. And then we're going to do the tongue too, because the tongue will start at that 24-hour mark. For infants, Tylenol around the clock for up to 3 days is very necessary often. Sometimes we can go down to a half dose the second day, maybe in the third day. Some parents choose not to do Tylenol. In those cases, I do really encourage using Arnica Montana. Arnica Montana, any dosage, I don't care. They come in little pellets. Do not use gel on the babies, just the pellets. You can put 5 pellets in an ounce of breast milk. You can do less if you'd like, but 5 pellets in an ounce of warm breast milk preferably. Let it dissolve. Keep that in the refrigerator for up to a week. You can use that anytime, all the time on the wounds. Clean hands, put a little bit on your finger, let it drop right onto a wound, or have the baby suck it off. You can rub it onto a wound. You don't have to rub the wounds. It's better just to stretch the wounds. Try not to touch them, rub them, but you can. Arnica Montana is great. For your older kids, 6 months and older, we can actually use Arnica Montana as well. But here we're really getting into more like, hey, it's safe now to use Motrin. So we can use Tylenol, Motrin, piggyback those in Arnica Montana as well. The kiddos that have sutures, we don't stretch those wounds. We don't have to do those lifts. We don't want to do those lifts, so we can pop the sutures if we did. Myofunctional, though, is going to be a critical thing. So we're functionally using the tongue, the lips, in a way that alternates between function and rest so that we get the best possible outcome. Myofunctional therapists are necessary. I won't do a release on a child 4 and over without a myofunctional first. So that's the only real restriction I have with any therapy that's needed always before, is that for my 4 and over. But really 6 months and over, I prefer myofunctional because a lot of kids, even those without tongue ties, have low tongue posture, really bad oral habits, and myodysfunction. So having a myofunctional therapist almost any age is critical in order to thwart things like sleep apnea later in life, or open mouth breathing, nasal congestion that develops secondary to that. And of course, nasal congestion can develop from anything, allergies and other things, but then that can also then therefore lead to open mouth breathing, and it's just a vicious cycle. So myofunctional therapy is wonderful for that. Pain management we've gone over. For infants, it's really, really important for parents to know that pain can be an issue. Infants can't talk, and toddlers somewhat, and that's even, still a mystery. But for the infants, are really hard to deal with because they are colicky or they're resting well. And if they're colicky, it can be really tricky. So sequestering away from family, away from friends for up to a week for really young infants is a very good idea. I really encourage mom and baby to be together as much as possible. If a colicky baby develops because of pain from the procedure, some babies show really no sign of pain, and others significant, where they don't want to even bottle or breastfeed. And we have to use our Tylenol syringe to get the formula or the breast milk into their mouth to stimulate them, usually within 2 hours, to get back to breastfeeding, bottle feeding. So there's the extremes, no pain or very severe pain. I want parents to know that going into it, that infants could be colicky and unconsolable. And that's where skin to skin, mama and baby time come in so critically. Warm bath, kind of a quiet, darker room, nice, beautiful classical music. Sounds crazy, but it works. I've had some parents say, thank goodness for your suggestion. It saved me. It was the only thing that got our baby to calm down. That is a worst case scenario. Most babies are not that extreme and don't have that much pain, but it's good to know what to do if you need it. I've got other tips and tricks on some of the post-op materials we'll give to parents, but without sutures, lifts are necessary, and that is lifting that lip completely up to the nose for 5 seconds, and it's lifting the tongue completely back, all the way flat for 5 seconds. And again, most of the time, that's 3 times a day, every 8 hours for up to a month. For the tongue, for the lip, it's usually 1 to 2 weeks, sometimes even a little shorter. I wish you the best of luck. Please call me if you have any questions at any time. You have my cell phone number. Obviously, the office number is even better to call because if I'm with patients, I won't have my cell phone on me. You've got this. Don't give up. It's worth it in the end.